Hi, I'm Igor, and today we will go talk about giant cell arteritis. Giant cell arteritis is a type of autoimmune vasculitis that causes chronic inflammation of large and medium-sized arteries, in particular the carotid arteries, its major branches, and the aorta. Epidemiology. Sex is more common in women than men. Peak incidence between 70 to 79 years, rarely seen in patients less than 50 years. Women of advanced age are particularly prone to the disease. Etiology of this disease is unknown. Possible contributing factors include genetic predisposition, for example, human leukocytic antigen DR4, viral infection, parvovirus B19, association with polymyalgia rheumatica. Pathophysiology of the disease. Giant cell arteritis is thought to be due to cell-mediated immune response to endothelial injury. However, the initiated factors are not fully understood. The first stage is inflammation. Activation of dendritic cell in the adventitia of blood vessel walls lead to dendritic cell recruits T helper 1 cell and CD8 T cell and monocytes. Monocytes differentiate into macrophages and giant cell which produce cytokines, for example, interleukin 6, tumor necrosis factor alpha, that augment the inflammation response, focal granulomatosis inflammation. Second stage is local vascular damage. Macrophages produce metalloproteinases that leads to destruction of vessel wall structure, internal elastic lamina. Most commonly involve external carotid artery branches, especially temporal artery, as well as the aorta and vertebral arteries. And the third stage is concentric intimal hyperplasia. Macrophages and giant cell produce platelet-derived growth factor and vessel endothelial growth factor and stimulate intimal proliferation and leads to reduced blood flow and ischemia. Clinical features include fever, weight loss, night sweats, symptoms of anemia, fatigue and malaise, myalgia, arthralgia, mainly of the shoulder and hip joints. Mnemonic for temporal arteritis is temporal. T means temporal artery tenderness. E means erythrocyte sedimentation rate more than 100. And M is multinucleate giant cell. P for pain. Or onset, more than 50 years old polymyalgia rheumatic association. A. Amaurosis fugax and loss of vision. L. Cranial giant cell arteritis involves the extracranial branches of the common carotid, internal carotid, and external carotid arteries. The temporal artery is the most common affected vessel. New onset unilateral or bilateral headache can be pulsing, throbbing, or dull, typically located over the temples. Hardening and tender temporal artery, jaw claudication, jaw pain when chewing, vision loss due to inflammation and occlusion of the ophthalmic artery and its branches. And scotoma, amaurosis fugax, or permanent loss of vision due to anterior ischemic optic neuropathy, diplopia. Is hardening of temporal artery. Clinical feature of arterial inflammation also include angina pectoris, acute coronary syndrome, abdominal pain, limb claudication, asymmetric pulses, asymmetric blood pressure, vascular bruits, aortic regurgitation, murmur, feature of abdominal aortic aneurysm, aortic dissection, thoracic aortic aneurysm. About 50% of patients with giant cell arteritis also have polymyalgia rheumatica. Demonstration of arterial inflammation on imaging and/or histopathology is required to make a diagnosis of giant cell arteritis. In patients with feature of cranial giant cell arteritis, the ACR classification criteria for giant cell arteritis can be used to differentiate giant cell arteritis from other forms of vasculitis. If giant cell arteritis is highly suspected, diagnosis should not be delayed. The initiation of high-dose glucocorticoids to minimize the risk of vision loss. Laboratory studies. Inflammatory markers. Initial laboratory test in suspected giant cell arteritis increase erythrocyte sedimentation rate, especially more than 50 mm per hour due to Rowlax formation of red blood cell, increased C-reactive peptide. Additional laboratory tests include normal or mild thrombocytosis, leukocytosis, or normochromic anemia. Liver chemistries include normal or increased alkaline phosphatase, increased transaminases, or a decreased albumin. Coagulation studies normal or increased fibrinogen. Indication: considered in all patients with suspected giant cell arteritis. Biopsy. Clinical feature: high clinical suspicion for giant cell arteritis despite inconclusive finding on imaging. Findings. Next slide. I include photo. Important considerations. The minimum length of biopsy is 1.5 centimeters. Histopathology may be false or negative due to skip lesion. Do not delay therapy for the result in patients with high clinical suspicion of giant cell arteritis. Temporal artery biopsy with histopathology is only test that can definitively confirm giant cell arteritis and should be considered in all patients, especially if giant cell arteritis cannot be ruled out with imaging. Temporal artery biopsy is gold standard. Findings on biopsy. Panarteritis of the large and medium-sized arteries, proliferation of the intima and subsequent stenosis of the artery, necrosis of the media artery, the media size of artery, fragmentation of the internal elastic lamina, and predominantly mononuclear infiltration of vessel wall with formation of giant cell. Duplex ultrasound indication. Duplex ultrasound of the temporal artery is the first-line imaging technique in suspected giant cell arteritis, supportive finding edema and thickening of the vessel wall halo sign, non-compressible arterial compression sign, stenosis, and occlusion. The characteristic diagnosis finding in giant cell arteritis are rise inflammatory markers in combination with evidence of vascular inflammation on imaging and/or histopathology. Treatment. In the base treatment is glucocorticoid therapy. This is the mainstay of treatment for patients with giant cell arteritis. Initial high-dose therapy, induction therapy. Indication: all patients with new onset or recurrent giant cell arteritis. Important consideration: initiate before diagnostic workup before biopsy if clinical suspicion for giant cell arteritis is high to minimize the risk of complications such as vision loss or stroke. Option: uncomplicated disease or oral glucocorticoids and prednisolone. For example, prednisolone. Ischemic organ damage, impaired vision. Consider initial pulse therapy with intravenous glucocorticoids before oral glucocorticoids. Pulse therapy with methylprednisolone or glucocorticoids initial or following pulse therapy. Prednisolone. Immediate administration of high-dose glucocorticoids is crucial to lowering the risk of permanent vision loss in patients with giant cell arteritis. Mainstay therapy is slowly taper glucocorticoids to the lower dose needed to control symptoms. Administer prophylactic measures to prevent complication of glucocorticoid therapy as needed. Glucocorticoid-sparing therapy indication. Consider in patients who relapse or are at high risk of complication from long-term glucocorticoid therapy. May be used to decrease the dose of glucocorticoids. Options include tocilizumab, antagonized with interleukin-6 receptor, and methotrexate. Low-dose aspirin not routinely recommended, considered in patients with pre-existing cardiovascular or cerebrovascular disease. Complications include the first, the permanent vision of loss if giant cell arteritis is left untreated, cerebral ischemia, transient ischemic attack and stroke, aortic aneurysm, and or dissection. Thank you. Subscribe to the channel.